And we're going to go ahead and start. But first, let me talk to you about the Spiritual Care Network. For those that have never been on one of our webinars, the mission of the Spiritual Care Network is to bridge the gap between mental health and faith. And we do that a variety of ways, one of which is to offer professional education and have really good experts in the field talk and give a monthly credit. And we are just really blessed and thankful for the people that come forward and offer to educate us in the industry. We also offer networking opportunities to get to know the resources in the community all throughout Texas. And we have 11 different groups around Texas, but we offer these webinars to reach not only Texas, but outside Texas. So feel free to use the chat box and tell everybody where you're from. Next month, the webinar will be led by Dr. Jason Powers from Positive Recovery. That's going to be a great topic. Also for the ministers and faith leaders, anybody in a ministry, we offer a forum every month to come together and talk about what's going on in our churches and our ministries. And the next one is going to be February 4th. And that is going to be a discussion topic led by therapist Carrie Breedlove from Denton, Texas. And that is very powerful. And we have worship music and prayer time. And it really gives us an opportunity to bring the churches and the ministers into the Spiritual Care Network. So look for those updates as well as in-person networking events in your area on our Facebook page and on our email blast, and reach out to me if you're not on that list. So I'll be glad to add you. My name is Eric Ayles. I'm board president of the Spiritual Care Network. I work at Starlight Recovery Center in Center Point, Texas. We're an addiction treatment center, and what we boast that we're the oldest addiction treatment center in Texas, only older than 60 years old. And I'm very passionate about our spiritual program called The Journey. We have a beautiful chapel on campus, and we have worship time on the weekends and Bible studies through the week, and a Christian therapist that work with our clients that want to have that little extra during treatment. For more information, go to starlightrecovery.com. So also let me introduce a good friend of mine, Rick Matthews from Starlight. Serenity Light, Rick, I'm getting all these lights mixed.
Oh, whoa.
It's very tricky here. So Serenity Light Recovery. And tell us a little bit about your program, Rick.
Yeah, thank you. Yeah, I love these new formats where you're sitting at home. I have 2 dogs at my feet and my 9-year-old grandson over here on the side doing homework for school. So these are pretty fun. But yeah, we are not the oldest. We're going into our 4th year here at Serenity Light Recovery. Actually, Kristina has been with us since before day 1, getting everything set up and started. But we're an alcohol substance abuse treatment facility, Joint Commission accredited, licensed, in network with most of the insurance companies. Still working on some others, but we're just down in Angleton, a little bit south of the medical center, on 10 acres. So very nice, serene place there to be. A lot of holistic treatment, and we do a lot that where we can truly meet people where they're at. So we can typically have about 6 clients per therapist. So we do a lot of individualized treatment there. Some higher acuity medical on the detox as well. And, just like I said, a lot of holistic, acu-detox and massage therapy and equine therapy and art therapy and certified personal trainer and certified yoga instructor. So, everyone gets nutritional assessments. So we do, very much treat the whole person. So good place to be, and some really good therapists and programs that we have. So SerenityLightRecovery.com. Check us out.
Thank you, Rick. Awesome. Well, before we introduce Kristina and the topic today, let's just open up with a word of prayer. Dear Heavenly Father, just thank you for bringing us together virtually. And I just send out a special prayer of support and wisdom to all the professionals on this webinar today. And thank you so much for bringing Kristina to share her knowledge of this great topic, and just help the spiritual network grow and guide us and lead us. And thank you for all your blessings. In Jesus' name we pray. Amen.
Amen.
Righty. I'll turn it over back to you, Rick, to introduce Kristina.
Kristina, I've known Kristina for 4 years. I still cannot pronounce her last name. So she is just Kristina. I'll let you say that in a minute when you, but yeah, so Kristina was our clinical director, now has her first son, Max, who is 6 months old, and he's been at the facility I don't know how many times, never heard him cry. He's just awesome. So Kristina has decided to spend a little more time with Max. So she just recently, January 1st, moved from clinical director to be our director of programs and compliance. So, but you know, LCSW, LCDC, and just is a great counselor and a great leader for us. So we're blessed to have her with us here. So, and she does really well at these presentations, even though she gets really, really nervous. So now that I've put you on the spot,
yes,
all yours.
Hi, thank you so much. Welcome everybody, and thank you. It's Zetlmeisl, Zetlmeisl. I know I don't expect anybody to remember that. And like Rick said, I'm always so nervous to do these presentations, especially when I can't see any of your faces. And so it makes it just a little bit tougher. So bear with me. As he said, I have a little one, Max, so hopefully he'll be quiet, but you know, kids. So I'm excited today to be with y'all, excited and nervous, to talk a little bit about mental health and the differences that we're seeing in gender. I'll also talk a little bit about substance use disorders under the mental health umbrella, and not only what the research shows, but kind of what we see in treatment as well. And one thing to note before I pull up my PowerPoint here is that a lot of the research that the World Health Organization and SAMHSA put out it has been from 2017. So I think we'll all keep in mind that next year or in the next 3 years that our research is going to be much different after living through a pandemic, when many of us are isolated, working from home, you know, not able to collaborate and to socialize like we're used to. So I really think that this is going to have a big impact on our mental health, and that we'll see some probably rise in the mental health numbers. So let me go ahead and share my PowerPoint here, hopefully. And let's see. And Rick, you want to give me a thumbs up if you can see it?
I can see it.
All right, perfect. All right. So today we're going to go over just what mental health is, identify a couple different risk factors for mental health overall and in general. And then we'll start to get into some of the gender differences, symptoms and prevalence. A lot of times there's significant differences in what we see in males versus females and how these symptoms are presenting. We'll talk a little bit about childhood messaging and cultural norms, expectations, and how these may impact barriers to treatment. And then hopefully we'll talk a little bit about hope for the future and how we move forward from this gender gap that we see. All right. So the World Health Organization talks about mental health in general as a way in which, or being able to cope with life, to cope with normal stressors. I don't feel like we're going through any normal stressors right now. These are unprecedented times, as they say. But having, I wouldn't say a good mental health, but having the ability to manage day-to-day stressors, the ability to cope with things, the ability to produce and contribute to society. And so when we look at the diagnosis or disorders, we're looking at those individuals who are presenting with symptoms that are impairing or impacting their ability to manage normal stressors. I always think it's important to say what, I may see someone and say, oh, they're definitely depressed, or they're definitely an anxious person, or they have, an obsessive compulsive personality. But if it's not impairing their day-to-day life, it's not impacting them, then it's not a disorder, right? It has to be impacting the person that has the disorder. And so we'll talk about a little bit about mood disorders, anxiety disorders. This may also include personality disorders and substance use disorders. So when we go through the statistics, I won't focus too much on them because I'll have a little bit on like the overview. But 1 in 5 adults in 2017 presented with a mental health disorder. And I think it's also important to note that this is just what we know about, right? And so when we talk about the gender differences or the cultural norms, we can only report on what we know. And a lot of times people don't talk about mental health, they don't seek help. And so it's probably a lot higher than we can even imagine. So the number one diagnosis was major depression, and that was 17.7 million people. And I think the second was anxiety disorders. And so, like I said, under the umbrella of mental health disorders, we're also including substance use disorders, and that's impairment due to recurrent substance use. So a lot of times this presents as physical health issues, mental health issues, inability to work, issues at home, a variety of different symptoms. And out of those, I think it was, what was it on this page? Yeah, 17 million, half of those, right, are presenting with a co-occurring disorder. So that means that they're presenting with both a substance use disorder and a co-occurring mental health disorder of depression, anxiety, bipolar, personality disorder. So that's pretty significant. So what contributes to us developing a substance use disorder or a mental health disorder? One of the number one things that you learn about when you're in school is biology. And I was looking into this earlier and looking into the ones that have the highest genetic factors. And I'd say that the highest genetic factors are going to be the diagnosis of schizophrenia, bipolar, and depression. And so I can't discuss all the brain and the chromosomes and all that, but I was looking at the reuptake of the production of calcium and how that impacts your mental health. And so there's a lot of research to do on the genetic coding that we receive from birth. But some of us, some of our clients aren't going to have any, family history of depression or anxiety or bipolar disorder. And so the other things that we'll look at, or that research looks at, that contributes to these diagnoses is our childhood attachment, our attachment styles, our locus of control. So whether we believe that we have the ability to impact the environment around us, trauma is one of my favorite topics, so something I can talk about at a different time. Our access to not only social support, but family support, our ability to ask for help. Do we feel like we're able to ask for help, or do we feel like we'll be heard if we do ask for help? Self-esteem, stressors and pressure, coping mechanisms, resources, and gender. And so each of these can be either a protective factor or a risk factor. If I have really secure attachments with my family and my parents, but have a history of trauma, I'm more likely to be able to cope with that because I have some sort of resource. Whereas if I have all of these things and trauma, no family support, poor self-esteem, poor internal resources, then it's going to have a more negative effect. And so we're going to go more into, gender here. So we've been learning a lot and seeing a lot more research done on gender, and that's a socially constructed expectation regarding the way in which we should behave based on our sexual classification. So it's not necessarily our sex, which is biological, but it's the way we feel internally and the way that we experience everything within ourselves. And as we go through today, we'll talk a little bit about how gender may be a risk factor. All right. So we'll see here, as I said, that the 2017 research, you'll be able to look a little bit about at the graph, and you'll be able to see that there is 22% were male or female, sorry, that were reporting prevalence of mental health in 2007 to 2017, and only 15% were male. And then you'll go over here and you'll be able to see the ages as well as race and ethnicity. I'll go through this on the next page. So I thought it was interesting, though, just to note that, while mental health in general, you'll see a higher diagnosis in women. When we look at substance use disorders, and in my personal experience working in treatment, I frequently see much higher numbers of men, right? And so those numbers are very different, even though oftentimes substance use disorders are under the umbrella of mental health. The data is much different on those two. So women, I thought this was really interesting. Women were reported to have higher rates of depression and anxiety disorders. So women usually present with more internalizing symptoms. So that's withdrawal, loneliness, depression, things that you don't always see on the outside, versus men who, as I said, have higher rates of both substance use disorders and antisocial disorders. So these are externalizing disorders. These externalizing disorders cause other people to take notice, maybe earlier on or more frequently than the internalizing disorders, because you don't always know when a person is anxious or depressed. Men's disorders often look like bad behavior, right? Acting out, impulsivity, aggression, frustration. And so the people around them take notice sooner, but often, as I said, see it as bad behavior rather than maybe the possibility of a mental health diagnosis. Let's see. So the World Health Organization tells us that these are often related to risk factors such as our roles, stressors, and negative life experiences. And it's not in this PowerPoint, but in other areas that I was looking into, a lot of those negative life experiences were things like I said earlier, the domestic violence and trauma, and domestic violence, sexual assault, and trauma are higher rates in women than men. But again, that may be due to the lack of reporting. So let's see. So we'll get into some of the gender roles, and this is the part where I wish I could, I will make sure and get to it at the end, but I hope if you can think of any gender norms or expectations that maybe you were raised to believe, some rules or family roles that you felt were more male than female. If you want to drop them in the box, we can talk about them later. But these were some of the ones that I noticed, or that I could, that I've heard in the past, is the kind of boys will be boys. It's a lot more acceptable for men to experience anger. When I was doing the Daring Leadership training and reading some of Brene Brown's books, she talks a lot about how it's more acceptable for men to be angry than to be sad or depressed, and how that was not reiterated, but reinforced by the people around them, right? So it was really hard, and even me personally, it's really hard for me to see, this is so stereotypical, but it's really hard for me to see like, a grown man cry, right? It like touches my heart differently versus a grown woman cry. There's something about it that is just different. And I think that's a lot of our cultural norms and the expectations that we've been instilled upon, and from our childhood. Men as children, or males often are told to pull themselves up by your bootstraps. They're taught that men don't cry. And then in adulthood, they're expected to be like the head of house, the breadwinner, and this will put a lot of pressure on them. And I noticed myself, I have a son, and I can already see like trying to, make sure that I don't do these things, which it's already so ingrained in me from childhood that I can notice some of the things I say to me 6 months. He doesn't understand me, but I know he will understand me. And so like I said something like, people aren't going to want to come visit you if you keep crying, Max. And immediately I went to like, oh, well, this is where shame comes from, right? This is exactly why we exhibit some of this, because I'm telling him it's not okay to cry. And so I laugh, but in all seriousness, it's something for me to take a look at as a mother, as a leader, as a therapist, all of those things. So women, childhood messages, in at least in Western culture, we see anger as unladylike, or it's minimized, like, oh, you're so cute when you're angry. In adult women relationships, venting is encouraged. And while it's important to have those positive relationships, oftentimes when we're just venting or we're focusing on the problem, right, rather than having healthy intimacy, there's a lot of intensity that comes from this. And it says venting is encouraged, but because of this, because we do have some more relationships and because we are more likely to talk about things, we are more likely to reach out and ask for help as well. And then one thing that I've been recognizing just in my own experience is like this mom culture of like drinking. So I'm in, mom groups and things like that. And it's, there's so many people like, well, it's noon. Is it acceptable to have a glass of wine yet? And, people cheering each other on. And I know that they're trying to support, but there's this acceptance of like day drinking, which is drinking in isolation, which, can lead to other issues, obviously. And then some of the other issues that comes up in this is that the mother usually has multiple roles. So today, the research shows that more and more women are working, but they're also expected to be the primary caregiver of the child. So with this, there's oftentimes like the inability to participate in self-care, hobbies, relationships, leading to more isolation, which then again leads to more mental health. Let's see. So other cultural norms and just overall is that alcohol use is normalized. Drug use is often demonized. So what that means is like drugs are bad always. And while we can all agree that drug use is bad, we don't have to look at the behavior rather than talking about addiction, having normal discussions about mental health. I think that contributes significantly to the stigma that we're seeing and the reason that people don't ask for help. And these things are rarely discussed as illnesses. So we'll talk a little bit about stereotypes, although I'm sure I've talked about them already and probably didn't even recognize that I was using them. Some of the stereotypical symptoms that you'll see in men is substance use, irritability, as I said, impulsivity, isolation. Oftentimes it won't present, but there may be some low self-esteem and mood swings. There's often also higher rates of completed suicide. So while more women attempt suicide, more men complete suicide. Women, some of the stereotypical symptoms, and when I say stereotypical symptoms, it's like what you think of immediately. But because of these stereotypes, we often have misdiagnosis, or we don't know that people need help because we're not looking at this as a mental health. We're looking at this as a cry for help, or not. Yeah, we're not looking at this as mental health problem, but more as like a cry for help, or someone being dramatic or hysterical, rather than thinking like this is an illness, this person needs help. And you can do research on like hysteria, and there's like a lot of interesting research out there. But yeah, crying, we think of crying, isolation, shame, low self-esteem, self-harm, and mood swings. And as I said, when you don't present with just these symptoms, I have clients all the time that say like, well, I don't think I'm depressed. I don't ever cry. Or, I'm not sad. And so this presentation isn't necessarily on depression, but just because you don't meet these stereotypical symptoms doesn't mean that you're not suffering with mental health disorder, right? And so taking a look at, some of the criteria and doing an assessment and being able to see, okay, I'm lacking pleasure. I'm unable to participate in day-to-day life. I'm sleeping 12 to 14 hours a day. These are things that we don't always see as depression because we're thinking of these stereotypical symptoms, which there may be too. So I'll give a couple examples and just note that I know they may be extreme. Kind of tried to make them a little bit more extreme to show to be able to show it through here. So Monica, a 32-year-old accountant, she's married with 2 children. She experiences frequent crying spells, shame, isolation, and binge eating. So her example, when returning from home, she finds her young children yelling in the living room. She's unable to cope with her feelings, brings a pint of ice cream and a bottle of wine to her room in tears and calls it a night. So Monica manages her emotions through excessive sleep, alcohol use, overeating, and self-sabotage. And then we have James. He's also a 32-year-old accountant and has 2 children, but he presents with more irritability, inability to cope with like the small irritations, anger outbursts, and substance abuse. So when he returns at home after work, he becomes irritated with his children who are playing loudly, slams the door, yells at his children, blames his wife for their behavior, and frequently feels guilty afterward for lashing out at his family. He begins to drink nightly as a way to manage his emotions, anger, and difficulty falling asleep. So Monica's family and work becomes concerned with her behavior, and we'll talk about this in a second. As a result, though, she seeks therapy and is diagnosed with depression and placed on Lexapro. James is more rewarded for his behavior. He's promoted and seen as a leader. James's primary care physician, aware of his issues, does not see a need for his diagnosis. However, eventually James begins to seek AA meetings, but never gets treatment for his underlying depressive disorder. So both of these people could meet criteria for depression and alcohol use disorder, and maybe a binge eating disorder. But both are going to get different treatment, likely based on their gender. And so we'll go into this. And I'll go through here. So 2 out of every 5 people suffering from a mental health disorder will seek treatment in the year of onset. So what that means is only 2 out of those 5 people that are experiencing those symptoms that we just talked about are going to actually reach out and ask for help. So Sampson notes that 47% of females receive services compared to only 34% males. And as I said earlier in the presentation, this is contradicted when we look at substance use disorders, or if you go into treatment for a substance use disorder, usually it's, I'd say 60 to 70% male to 30 to 40% female. If you attend a support group or a 12-step meeting and you're a female, you're likely, it's not abnormal to be the only female in that meeting. So there's a discrepancy there. And when we looked at both the examples of Monica, so women are more likely to seek help from their PCP, their psychiatrist, or a counselor. They're also have much higher rates of being prescribed psychotropic medications, so antidepressants, anti-anxiety medications. Men, because like we talked about earlier, sometimes it's seen as like bad, quote unquote, bad behavior. So usually it's they're seeking help because they're pushed by their family members, their mothers, sisters, wives, their employee assistance program, or legal counsel. So the way that we get into treatment is going to be completely different too. And males, as I said, are more likely to disclose substance use disorders. So some of the barriers to treatment and the reason that only 2 out of 5 people are going to seek treatment, the number one is stigma. And I think a big part of the Spiritual Care Network and all of our work as people that are, individual therapists. I saw people that were, working at, in Harris County, just different areas. One of our big goals is to reduce stigma and asking for help. Other people have privacy concerns. They may not have support or the ability to do that. As we've been talking about, is misdiagnosis. So because I'm a female and my spouse is a male, I'm more likely to be diagnosed versus him not being diagnosed, because his may present as anger, aggression, all the things we talked about, whereas mine, maybe isolation, crying, shame. Resources. So internal and external resources are going to be a barrier to treatment. Internal resources being like my ability to just cope, and then external resources being finances. Insurance. Do I have insurance? Do I have the ability to just up and leave? Family roles. So again, do I have the ability to leave my job if I'm the primary the person that's in charge of finances? Also, do I have the ability to leave if I'm the primary caregiver and I'm taking care of our 2 children? I've seen a lot of this, in the pandemic with people who have multiple roles. So now all of a sudden you are a mother and a father, and you have to be a teacher, You're also supposed to be their best friend, right? And so you have all of these complex issues that have arise from us having multiple roles within our home, within our organizations. And it just more complicates the ability to ask for help and the ability to take time apart for ourselves. Fear might come into play, denial, and then cultural beliefs as well. So some of the options for treatment, and I'm sure a lot of our participants offer a lot of these. And so I think it's important to note that there are so many ways to get help. But if we don't understand what it is that we're looking for, and if we're living in stereotypes, then we're often going to miss out on people that need help, on people that are unable to communicate and say, I need help, and instead are acting out in substance use disorders or impulsivity or oversleeping or overeating. So individual therapy, I feel like I'm going way too fast. Sorry, guys. I'm a fast talker plus nervous. So yeah. So options for treatment, individual therapy. A lot of times, as I said, males tend to utilize EAP benefits, and that's through an employee assistance program. And you can get a lot of variety of different options whenever you go through your EAP, whether it be a referral to that individual therapist or a referral to a psychiatrist. And oftentimes, if you work at a bigger organization, you'll have a certain number of sessions they're able to utilize as well for free. And there's also group therapy, IOP, partial hospitalization programs, residential treatment, inpatient, detox, recovery and life coaching, psychiatrists and psychologists, and support groups. One thing to just think about, or that I think about when I think about our options for treatment, is that today, at least in the industry that I work in the substance abuse field, there's so many options for a primary diagnosis of substance use disorder. There are several amazing IOPs around the Houston area, and worldwide, but not worldwide, in the United States, but there are so many options, whether it be intensive outpatient or 12-step meetings or detox. But when we look at mental health, overall, what we're seeing, or what I see, which may be biased, is that there are just a lot of stabilization. Our insurance, and it's very insurance driven. And so we have a lot of stabilization, a lot of inpatient that lasts 3 to 7 days. And so our friends and our families that are suffering with mental health disorders are pushed in, they're stabilized, they may be given medication for 5 to 7 days, and then they're put out back into some of these environments that may be some of the reasons that they're experiencing this, that may be some of the risk factors, right? The trauma, the abuse, the poor impulse control, the stressful work environment. And so I think that's really an area that I'm hopeful that we can improve together. And I think that's why we have organizations like this, to bridge the gap and be able to come up with the resources that are needed for those that are suffering with mental health disorders. Because it's a lot harder to have long-term care, right? There isn't as much out there for a primary mental health disorder. And oftentimes, unless you're a direct risk to yourself or somebody else, you're not going to get that care. And so we wait until someone is threatening harm to themselves or is having homicidal ideation before they're approved to meet medical necessity to get treatment. And so I think that that's another barrier to treatment, both for males and females. And I think it's definitely a problem with our system. It's a little off topic, but important to note, I think. Well, I guess I didn't time this well because I'm going to be done early. But I think that, as I said, part of what we have to do as a culture and as a society is normalize help-seeking behaviors. Normalize that it's okay as a 10-year-old girl to be angry, and as a 10-year-old boy to cry, right? And so coming back to like this gender neutral, coming back to this place of being able to be acceptable to ask for help when you're struggling, to start using different language when we talk about substance use disorders and we talk about recovery for mental health. also educating on mental illness. I was talking to some of my colleagues last night, and I can't recall what the specific class was, but I was just thinking, I never learned about mental illness when I was in elementary or middle school. Nobody talked about it. And they said, I think that both of their children, or one of their children, was in a class on, emotional health. And they actually did a screening tool in school. And so that was really promising to me, because I feel like if we're able to talk about this early on in life, and we're able to normalize it, like, it's okay to ask for help. It's okay to go to therapy. You don't have to be suicidal, homicidal, on the verge of divorce, or so depressed that you can't get out of bed in order to ask for help. Also, like I said, like we were talking about, is making treatment both effective and accessible to those. So making it accessible to women who have children at home who are working and being parents, to men who are also working and being parents. Being able to get out there that it's okay to ask for help, and that it doesn't make you weak. It doesn't make you any of the things that we kind of have thought about in the past, and that we all have our personal experience with. So I guess in summary, even though I did it really short, although men and women are equally likely to experience mental health symptoms, it's going to present much different, right? And if we're not aware of the way that it presents, if we're not tuned in and making this individualized treatment that Rick was talking about, then we're going to misdiagnose people. We're going to misdiagnose men with bipolar disorder when it's really just depression, or we're going to misdiagnose that men have depression, right? Because it just sometimes looks like anger. And so although they're just as likely to be at risk for it, and they have all this very similar risk factors, it's going to be different. And then I think it's also important to note that we're going to have skewed statistics based on our social norms, cultural norms, our culture, our biology, and the acceptability of treatment. And so I don't know how to end this, but I think it's really important to talk about. And I hope that, in this time where there's so much virtual health available, that we're utilizing it. I've seen so many new resources on social media, on email, just of having virtual IOPs or virtual counseling. There's so much out there that's underutilized. And I know that all of us in this time are going to need some more support and assistance to get through such a strange and bizarre time. So I think that's all I have. I know I can't see the clock. I'm early, so
Awesome.
I'm
We have
early
plenty of
and
time.
well, it's plenty of time
That's
for
fine.
questions. But
Yes.
you, everyone gets to see you for an hour, even though it was only 40 minutes. I'm sorry, guys, but thank you so much for all listening, and I hope you'll have some good questions so that we can talk about this a little bit.
Yeah, great information and good presentation. I thought it was fascinating. I heard a similar presentation by Dr. Casey Green, and he was, of course, he's a doctor, and he was talking about how the physiological differences, body chemistry and hormones and all that really goes into play, especially with specific drugs and specific alcohol, and how it affects the body and mind too. So.
Yeah, I was actually looking at a similar PowerPoint, and looking at, the role of testosterone, and that part of this is also our biology, right? And so that's some of the symptoms are, a physiological difference. And then, as I said, those genetics that have such a huge role in developing these, and also there's like this neuroplasticity that rewires our DNA, that changes us when we have recovery. So it's also a positive thing too, that we can pass on recovery and healing, not only through, nurture, but also through our DNA, or change DNA as we begin to change.
Yeah, and even with the way our bodies work, different vitamins are depleted because depending on the drug in the alcohol. Right. And I would love, here's a $1 million idea for anybody out there, to design supplements for people that are in recovery for males and females. And so there you go. There's $1 million idea.
Yeah. I was saying that just before this PowerPoint, I was looking some stuff up, and there was, like I said earlier, there was some information about like calcium, like the differences, and male and female, and the ways that we process that. So let's see if there's any questions on here. I'll let Eric and Rick go to if there's any Q&A.
Yeah.
Okay. Well,
Yeah,
Linda,
actually, yeah, there was one from Sandy. It kind of goes back into what you're talking about. Would really like to hear more about your thoughts around transgender population and persons who don't identify with a gender with regards to stereotypes.
I mean, I think that I have so much. I'm trying to go back to the reference slide for someone on here. Let's see. I think that's like an entire another topic, but in something that I have so much to learn about. And I'm currently working on doing that within our organization. We've had a lot of discussion on how, to continue to be inclusive and to continue to educate ourselves. But I think that, sorry, I got distracted by the chat. I think that there are going to be significant stereotypes and significant other barriers to accessing treatment that are going to have to be addressed, especially, whether or not you identify with a gender. I think that these stereotypes are still going to be there. And so there's probably going to be a lot of misdiagnosis, a lot of people afraid to seek help. And hopefully, as we continue to grow in inclusivity and education, we're better able to treat people that are experiencing depression and anxiety in a transition or during this time. Let's see. Trying to get back to my reference page for you. And Linda, you asked if there was any notes available for you to print. I can definitely make this accessible. I'll send it to Eric.
yeah, that'd be great.
I haven't. Yeah, go ahead.
I could post your notes if that's okay on Spiritual Care Network page, and I'll put this in the link. But the Spiritual Care Network website is spiritualcarenet.org. So I'll post that on there and also put the recorded YouTube video on there as well, so we can watch this over and over and over.
Yeah. And just a note, I haven't been in school in about 8 years, so my reference page is probably not the best. So if you see some errors on there, that's why. Yeah. Let's see. Anybody else have questions or feedback? I know there are so many things that I've left off here, and there's just so much that's lacking in our research. So I hate to just stick to like the stereotypes, but I think it's so important because there is so much misdiagnosis, as I said. Even I myself, because of my own personal bias, may see someone and again think like bad behavior, a client that's not coming to group. My assumption may be they don't want to come to group. They don't really care. Maybe they're not ready. Like those are the things that I may think in my mind. But when I can take a step back, I can see that this person is probably struggling, right? That there's a reason. Nobody wakes up in the morning and is just like, you know what, I'm really going to piss my family off. I'm really going to harm people, or I'm really going to, just not do anything today. Most people are really doing the best that they can. And if I can come from that place of really thinking that people are doing the best that they can and really seeing that there's something that they're missing or lacking, and how can I add to that, coming from a strengths-based perspective, I think we'll probably live in a little bit of a better place.
We have another question from Mike Campbell from Fort Worth, from the Spiritual Care Network group there. He says, I know there are many recovery systems. What is the % of faith-based recovery in today's world?
I don't know that answer, but I know that many people are incorporating faith-based programs. I can speak to, and I know Rick talked a little bit about it. Eric talked a little bit about the Journey program where he works. But I think incorporating faith into recovery is becoming more and more prominent. Although we see a lot of treatment centers that are 12-step based, there's also a component of prayer that usually comes involved. And for us, we have a spiritual director who does a prayer ministry and does a lot of spiritual coaching as well. And Celebrate Recovery has gotten larger and larger. I know they're having some meetings online, but it's definitely one of those internal and external resources that will help the individual in the healing process. I don't know if that answered the question, but I don't have a statistic, but I'm hopeful that it's increasing.
That is a great question. And we've actually had some people interested in putting together a resource guide for the Spiritual Care Network on faith-based, programs in the industry. We do have a page on our website that gives some resources and some groups that meet on different belief systems, which is interesting to me. So yeah, once again, that's spiritualcarenet.org. Rick, do we have any more questions?
I don't see any.
Let's see. Oh, there's another one in the chat. Why do you think the trends change for mental health and substance abuse? Women are more likely to seek mental health help, but men are more likely to seek substance abuse help, or the trends show that?
Yeah. I mean, I would just be a personal, my opinion. It wouldn't be statistical or research, but it's just been much more acceptable for men to be alcoholic or to accept that they have a problem with alcohol. If you look at like all the 12-step meetings in the research or in all of the literature, it's all men, right? It's all male. It's all centered around the men. And I'm not really sure why that started. I guess in the 30s when all this 20s and 30s, when there was Oxford groups and AA and all of that, the people that were seeking help at that time were men. And so it's just kind of geared towards that way. So I'm not really sure. I don't think that there are tons of women who meet criteria for alcohol use disorder. But like I said, I think it just looks a little bit different. And oftentimes that impulsivity and aggression makes it more obvious to other people around them. So people are pushing them to get help because they're, acting crazy or they're impacting their job. They're in more high risk, not high risk, but in the roles that they have in society and in their jobs, people are more likely to be aware of it. The people around them are more likely to be aware of it, I think.
Yeah, and I would like to get Rick's point of view too, as a business development professional for many years. It seems like when I get calls from men, it's from the legal system, from their employers, EAPs, from their wives. But for women, it seems it's more their children or their parents. And so we get different calls. What do you think, Rick?
No, I think that's exactly right. And I mean, so I'm typically telling if a male is calling me for himself, it's like, I know that was a hard phone call to make. And so, I'm proud of them for even making that call there. So it's very much so. But we do get a lot of wives and mothers that are calling for the males for us into the substance abuse side of it, for sure.
Interesting. And Diane asked, do you have any approaches or resources to addressing gender identity with youth and adults who are struggling with their identity that incorporates a biblical perspective?
I do not. That is a great question. And I am hoping that if anybody that is currently in this group has those resources, that you definitely add it to the chat box, because I think it's something that is so important. And, I've started looking into different books, but I can't say that it has that biblical or spiritual aspect to it, what I've seen so far.
That sounds like a good presentation in the future.
It does. It does. And I think that we're going to see more and more research on this and being, on this topic.
And kind of related, at Starlight, we have our spiritual program. Another program we have on campus is an LGBTQ plus program called the Freedom Program. And I have people ask me all the time, like, how do these two groups intersect?
Yeah.
And it's really kind of beautiful because the LGBT community, they feel free to worship and to express themselves and not be put down with the stigma or any of that. Because in our groups, everybody has hurt habits and hangups. And so there's not a lot of judgment. And I think that's kind of a cool thing.
It definitely is. I think that it's called the Freedom Group.
Great. Any more questions from our audience there? we almost hit 100 people from all over Texas. So that's really cool that everybody together for these presentations by the Spiritual Care Network. And once again, at the end, we'll post the link to do your evaluation, and you could print off your certificate. And then it's also going to be emailed tomorrow if you don't have time to do it right after this presentation.
Thank you so much for everyone for logging in. Although I would have rather there only been 3 people on here, wouldn't have been as intimidating. It was an honor for Eric and Rick to ask me to do this, and I hope to continue to learn and to continue to grow in the field. So thanks, guys.
You did well. Thank you.
Yeah, great information, great presentation, and good topic. And we really appreciate your time and your expertise. And thank you, Rick, for being our co-host.
Thanks for asking me. I appreciate it.
Yeah, let's do this again another time. And I will post this on the website. So if you want to share it with your friends then and your colleagues, it'll be there to view. And also I'll put the presentation on there as well. So. Great. Well, that's all I have for today. Thank you for joining us, everybody. And stay tuned for more great presentations, webinar, CEU events coming up in the next few months. So that's all I have for today. This concludes our webinar. Thank you.
Thanks, guys.
Thanks, guys.